Welcome, everyone. Thank you for joining us for today's webinar. My name is John Bond, and I'm leading the sales and marketing at Medmont. For over 20 years, Medmont has been one of the leading providers in specialty care eye space, and we look forward to working with you in the near future. We at Medmont are extremely excited to share with you today our final webinar in a series of 3. Introducing a new advanced topographer, Medmont Meridia. Today's session is titled as the Medmont Meridia Advanced Topographer, Best-in-Class Topography, now with dry eye applications. A short little introduction about our presenter. We are very excited at Medmont to have Dr. Wu sharing and educating today. Dr. Wu has been working with us in evaluating and providing useful feedback for further development of this very scalable platform. Dr. Stephanie Wu was born and raised in Lake Havasu, Arizona. She graduated magna cum laude from the University of Arizona with a degree in biology science education. She graduated with honors from Southern California College of Optometry. She completed a cornea and contact lens residency at the University of Missouri, St. Louis, where she was trained to fit highly irregular corneas. She was the recipient of the Gas Permeable Lens Institute Award for Clinical Excellence and the John R. Griffin Award for Excellence in Vision Therapy. Dr. Wu is a fellow of the American Academy of Optometry, a fellow of the Scleral Lens Society. She has also authored the Gas Permeable Lens expert column in the review Contact Lenses. She is a frequent author to publications such as Contact Lens Spectrum, Contact Lens and Cornea section of the American Optometric Association, Review of the Cornea and Contact Lenses, and Review of the Optometric Business. She is an active GPLI Advisory Board member. Dr. Wu is a past president of the Scleral Lens Education Society, a nonprofit organization committed to teaching the art and science of scleral lenses to practitioners. She's also an adjunct professor at Midwestern University. Dr. Wu enjoys lecturing around the world about contact lenses and anterior segment ocular diseases. She is the owner of Contact Lens Institute of Nevada. She also owns the Optometric Coaching and Consulting Program. For more information about this program, please look it up at drstephaniewu.com. In her spare time, Dr. Wu is an avid wine collector and is a level 2 WSET sommelier. Dr. Wu, I just wonder when you have time to drink, to be honest with you. With no further ado, it's my honor to let Dr. Wu take the reins. Take it away, Dr. Wu.
Well, thanks, John. And yeah, I'm sure that's a good question, but when you're involved in so many different things, of course, you always are going to make time for wine, as you probably know, and being in the optometry world and being around all of these fabulous individuals, it's always fun to share a drink at the end of some of the daily events. And just want to say thanks to Medmont for having me. This is really exciting for me to be able to be not only a part of the new topographer that's being launched, but being able to provide feedback for Medmont, and it's just been really an awesome integration into my practice. I'm really excited to share you guys with some of the things that we've done. And yeah, it's going to be tough to follow Randy since he's been lecturing the past couple weeks, but I'll certainly try my best. If you need to get a hold of me after this lecture, you can go to drstephaniewu.com. I also have Instagram and Facebook pages. I have some interesting case reports, and almost all of my Instagram and Facebook pages, I've got lots and lots of images from Medmont, whether it's the topography or the anterior segment camera or some of the other really cool features that we're going to discuss tonight. So thanks again to Medmont for having me. So if you are familiar with the Medmont, and if you've been following Randy's lectures over the last couple weeks, you know, he's always done a fantastic, amazing job at going over the topography and some of the features. And I think that with Medmont, the features that the topographer has is already kind of above and beyond a lot of the other topographers on the market, but also something that has been really exciting that Medmont kind of came together and figured out this is something that we need is dry eye applications. So I look at it as kind of like a 2-in-1. So we've got your amazing topographer, which has Medmont's always been incredible with that, but now it's also got a dry eye feature and multiple different tests that we're going to be able to go through. So now you have like these two amazing machines, but you know, it's all packaged into one device. So I think that this is an incredible option, especially for so many of us that are not only needing a topographer, but we also need something to be able to help treat and manage dry eye. So this is just something that we kind of wanted to present as far as a lot of visual impairment is preventable or curable. So of course, we've got lots of patients that have uncorrected refractive errors, and this is around the world. But the one that we kind of want to talk about tonight is dry eye. So 352 million people in the world have dry eye. And breaking it down, about 6.7% of all US adults, so that equals about 16 million people in the United States, have dry eye, and only about 45% of them are actually diagnosed. This represents a huge opportunity as far as growth within your practice. We know that the more that we're researching, and really when you're reading all these different journals in optometry magazines, and webinars and things like that, we're really finding that dry eye has become such a prevalence in the adult population and even in kids. When we're checking some of these measurements in children, we're finding that a lot of kids are starting to have symptoms of dry eye. And who knows if it's because of all the screen time, and with this whole COVID situation, that's not helping anything. Or is it because they're doing a lot of reading and up close activities? So dry eye is something that we see every single day, no matter what type of practice you're in. You have patients within your practice that have dry eye. And I think it's just really important to realize that as we get more and more advanced with technology, we're really finding that a lot of patients have dry eye that we didn't really even knew had it. And another thing that we have discovered over time is patients that are complaining of dry eye symptoms. You know, their eyes are scratchy, they're red. We're seeing signs on their cornea that they have damage. Those patients actually fall into that moderate category or even severe. So it's really important nowadays that we diagnose dry eye sooner so we can get them on a proper treatment protocol. Just like anything, any disease, early detection is key. So if we're able to diagnose and manage dry eye earlier, we're really going to help that patient throughout the lifetime of that patient. So this is something that's really cool because in the Medmont itself, you can actually check off these little boxes, and that will print out on the patient's dry eye report. So you're able to kind of look at some of these non-modifiable risk factors, modifiable, and then medicines. So if your patients have any of these things, you actually can just click these little areas, and then that will actually print out on their report. So they're actually able to see, oh, okay, I am a female, and I am Asian, and I do wear contacts, and I also use antihistamines. That will print out on their report, so they also have kind of a better understanding of why they have this issue. And if they, a lot of times when they see they have a lot of different risk factors, that really also kind of puts in their head, oh my gosh, okay, this is something that is a problem, and this is something that I need to do something about sooner than later. I just thought this was really interesting, that I just wanted to show kind of where we were in 1995 when it came to dry eye, and then where we are now, kind of in this 2017 era. And you can see that the definition of dry eye has changed significantly. In 1995, the dry eye workshop thought that that dry eye was a disorder of the tear film due to tear deficiency or excessive evaporation, which causes damage to the interpalpebral ocular surface and associated with symptoms of discomfort. But now we can see that dry eye is more complex than ever. The more tests we have, the more we're understanding what's going on with this disease. And really, I think this is definitely a more accurate and appropriate description. It's multifactorial. It is characterized by a loss of homeostasis of the tear film, and it can have hyperosmolarity because of the changes in the homeostasis of that tear film. It can be very unstable. It can have inflammation. The more and more we're reading and discovering about dry eye, we are finding that, wow, inflammation has a huge role in this disease. And I think that, you know, this definition might be changed in another 10 years. We might find more issues with dry eye that will re-change the definition again. But I think it's just really interesting to kind of compare what we knew in 1995 compared to now, and how much we have discovered about dry eye, and that just continues to change. So this is from DEWS 2, and this is just kind of a little flow chart of what's going on with the dry eye patient. So if they're symptomatic versus asymptomatic, and then it goes through different signs and symptoms and things, and then it just kind of goes into the different classifications. So we don't need to go through this entirely, but this is one of the newest and most recent classifications that we have now. And this was very different when I was in optometry school, that the different ways and the different ways of classifying dry eye, it's really all been changed, and some of the treatment options we have changed tremendously as well. And this is something else as far as the types of dry eye. This has also changed over time. We've got patients that have aqueous deficient, so meaning they're just not producing a lot of tears on their eye. We've got patients that are lipid deficient. We have people that have both aqueous and lipid, and then we've got a huge portion of patients that we just don't know why they have dry eye. I will say this is a really accurate kind of representation of what I see in my own practice of patients that, you know, a lot of patients have dry eye, and a lot of them are mixed. Some of them have one or the other, and then other times we don't know why they have this, even when some of their tests are showing that they're quite normal. So I think over time we're discovering that dry eye, you know, it's changing. So this chart today, I think, is going to look different in 1 year, 2 years, 5 years. So it's just really interesting for us as eye doctors to be able to see how dry eye has changed and what are the different treatment options that we can offer patients that have this. So with another you know, classification, you know, we kind of go with their symptoms, and that can just be from the dry eye questionnaire or OSDI. And then some of the markers include that non-invasive tear breakup time, less than 10 seconds. Their osmolarity, that's something that a lot of practices have now. And then also staining. But this is also something that has changed over time, and I think this will also continue to change. So as we discover more and as we gather more information on dry eye and the different classifications, it's really going to help us with our treatment protocol. So now we're going to kind of go over some of the features with the Medmont Meridia, and these are really, really exciting. So not only do we have the topography that Randy did such a great job describing over the last couple weeks, that is still an amazing asset, and we've got an even larger field of view there, which is incredible when you're fitting these complicated corneal cases. We've also got the enhanced tear breakup time, so it's a lot easier to capture, and I will say that for my patients, it's very easy. Some of these other systems that I've worked with, it's a little bit invasive, or it's very hard to capture the image, or it's really hard for the computer to know when to start filming. So I will say that with my use of the Medmont Meridia, the tear breakup time is very easy. It's not invasive, and it's easy to understand for the patient. Those are all really important things for me as a practitioner. Something else that I really, really love, and you can check out on my Instagram page, I've got lots of images and videos using the Medmont, but this is so powerful for patients. We need to have a way not only to be able to photo document what their eyes look like so we can see if they are changing, getting better, worse, or staying the same. So we need that photo documentation to see what's going on with their eye over time. But it's also a really powerful tool in office to show these patients what's going on with their eye in real time. And I have just discovered in my own practice that presenting the patient with these photos and kind of showing them maybe some before and after photos, maybe you get them started on a dry eye protocol, and then you see them back a month later or 2 months later, and you can show them the differences. That is huge, and that is going to really help with them maintaining compliancy throughout the dry eye program. So that's awesome. There's also fluorescein imaging and videos. So there's that, so it's very similar to like your cobalt blue light in your slit lamp. So that's great as well. Very important for me as a doctor who fits lots of specialty contact lenses. This is something I absolutely have to have. So this is an awesome addition to this as well. And then tear meniscus. So tear meniscus height is really important with documenting not only dry eye, kind of differentiating between aqueous deficient and then Meibomian gland issues, but also it can also help with tracking to see if the treatment protocol is working for that patient. For instance, if you have a patient and you say, wow, their tear meniscus is really low, and we put, let's say, plugs in, then let's check it in a week and see what happens. And when the patient can see for their own eyes, and you too as a practitioner, that, hey, this patient went from only having 0.1 millimeters of a tear meniscus, and now they're at 0.4, that is really, really great data, not only for you as a doctor, but to show the patient, like, look how much better your tear film is looking, and look how much more liquid you have on your eye now. So I really like using tear meniscus for lots of different patients. Meibomian gland imaging, that has become super important. If you're managing any dry eye at all, you really need to have some sort of a way to image the Meibomian glands to see what's going on with them. And the Meridia has a great technology with infrared lights to be able to show us what's going on with the structure of those Meibomian glands. And again, we can use it to not only diagnose, but we can see over time what's going on with those glands. Are they continuing to drop out? Do they look any different? So really, really interesting data. There's also grading scales. So not only can you take all of these images with the new Meridia, but you can actually grade it yourself. And then that's another way to show patients and yourself, are they making progress? You know, your conjunctival redness, I graded it as a 3 when we first started, and then let's look at it and see where it is today. So I think that, you know, just handwritten notes and in the chart is really just kind of secondary, you know, it's not gold standard care anymore. It's really having these photo documents and a way that you can actually see if the treatment is working or not. So I think having these grading scales are really important to track the progress of that patient. And then also there's the dry eye report, which is really important, not only for you as the doctor, but also for the patient, so that they can get a printout or have it emailed to them, whatever is the best for them. But it has not only photos of whatever you select to put on that report, but then it's got their treatment protocol. So if they have any questions, they can always refer back to that paper and say, okay, I'm supposed to be doing my eyelid scrubs twice a day. I'm supposed to be taking my fish oil supplements how many times a day. I'm supposed to be using these eye drops X amount of times per day. So giving them a report that they can physically take with them home, I think, is also very powerful and really important to having a compliant patient. So now we're just going to show you a few images of some of the new tests that are available with the Meridia. So this one is the non-invasive tear breakup time. A lot of us, have used Fluorescein for many years to track NIKBUT, but now it's really becoming more of the gold standard to do the non-invasive tear breakup time. So we can see on the video, after so many seconds, the tear film starts to break up. And I think it's also important that it shows the location. So those areas that are starting to become red, that's where the tear film is starting to break up the fastest. What I've noticed for a lot of patients is if they have, let's say, a pterygium in that area. So let's say it's in that nasal aspect, that tear breakup usually occurs a lot faster. And so they are able to see with their own eyes, oh yeah, that little bump or that little area on my eye that's giving me some problems, that it makes a lot of sense that the tear film is not stable on that portion of the eye. So this is something not only that's really good to show patients so you can they can see with their own eyes, because this is really easy for patients to understand when you have this color scale, but it's also really good so you can see if the treatments that you are working with are actually improving the patient's tear breakup time. So just a few pearls for NIKBUT. Make sure that you are performing this as one of the very first measurements compared to other things throughout the dry eye testing. And then repeat this test at regular intervals. And that way you can see with your own eyes and the patient can see with their own eyes, is this treatment actually affecting this measurement? So some doctors ask me, well, why can't I just use Fluorescein? Check for staining and then check the tear breakup time myself. I could just start counting. Okay, well, the reason that the Fluorescein installation is really not recommended is because it is associated with tear film destabilization, and that can create artificially different times. Other things that I thought about too, and that it just, when you think about it, it makes total sense is, well, what are you using to wet that Fluorescein strip? Are you using non-preserved saline? Are you using gas permeable lens solution? Are you using some other multi-purpose solution? So that's going to create some variability. Secondly, how much liquid is on that strip when you're putting it in the eye? Is it just a little bit? Is it a lot? And there's really no way to really measure that. You're just kind of wetting the strip and then putting it on the surface. And then three, me counting 1, 2, 3, okay, that is not very accurate. Just you counting in your own head is not as accurate as having a machine that's measuring it for you, and it's very accurate as far as the seconds go. So NIKBUT has definitely become more of the gold standard compared to just the Fluorescein breakup time. So that's a question that I get a lot. Here's some examples of some of the anterior segment imaging and the video. So you can see the camera that's on the Meridia is incredibly high quality. I mean, this whole system in itself is awesome, but the fact that the pictures are this amazing is one of the main reasons that I sought out Medmont, because I saw pictures of these photos of these patients, and for me doing so many specialty contact lenses, I was like, I have to have this because these images are incredible. You can also look, so see we've got an eyelid. So if you've got patients that you want to check their blepharitis or any other eyelid anomalies, amazing. So an incredible anterior segment camera and video. Here's some of my own patients. So on the left-hand side, we've got pictures of the scleral lens on the patient's eye. So I can see if there's any issues with the scleral lens fit. in the top here, we've got a patient that's got a pterygium. So great way to manage and photo document that pterygium, see if that is changing shape or size over time, and see if the scleral lens is compressing that area. And in this case, it looks really, really good. Below that is a picture of a patient that's got a microcornea and stem cell, limbal stem cell deficiency, and also a bleb. So a way to photo document that as well. Then we've got patients with corneal scarring and intacts in the top right there. And then below that is a patient that has pemphigoid. So I'm just checking to see that vascularized cornea with her current treatment program and the eye drops she's on and some of the medicines plus the scleral lens. Is she improving? So these are all really awesome pictures, and I don't think that any practitioner would disagree when they look at these photos. They're like, whoa, these are like so much better than a lot of the imaging systems that I've seen on the market. And that was one of the main reasons that I wanted to get involved with the Medmont Meridia, so I could take these really cool pictures and be able to have it for my documentation as a practitioner, but also be able to show patients at their own eyeballs. Here's another patient that I had that she came to see me because she had a trigeminal nerve issue, and she had a lot of corneal staining. And so I was able to show her, this is on the left-hand side is a picture of her when she was getting her scleral, the diagnostic lens fitting. And you can see that the conjunctiva, the blood vessels are a lot more angry. And just within 1 month, and for anybody that treats dry, that's not a very long time, but after 1 month, you can see her eye definitely looks more white, less inflamed, and this is just only after 30 days. So this also gives patients some reassurance that they are doing the right thing and they need to continue. And same thing with any dry eye protocol, when you show the patients their kind of before and after photos, they are a lot more likely to continue their program once they see with their own eyes that they are making progress. Here's some of the Fluorescein imaging and video, so you can see that if you do any sort of gas permeable lens, this is a great way to have photo document and imaging and videos, so that you not only can show the patient, but you've got that for your records. Also, this is wonderful to email to the consultant. So if you're not sure what's going on, so let's say on this left-hand image, you're like, well, should I be worried about this little bubble in this mid-peripheral zone? You can send that to whatever company, and they can help figure out if that's something that they want to adjust. So I have found that not only is imaging and videos amazing for your documentation as a practitioner, but also making sure that you're able to get that information to the consultant, so they are looking at exactly what you're looking at. And like let's just say with Randy, he's amazing at fitting these gas permeable lenses. What if I'm telling him, well, Randy, I'm seeing this little bubble, I don't know, it's just in the bottom portion, and then there's some excessive pooling superiorly. He has to think in his head, okay, I think I am understanding what Dr. Wu is saying, but he's kind of has his own picture of what might be going on. But when I send him this picture, on the left-hand side, Randy can look at it and he can say, I know exactly what's going on because he is seeing exactly what I'm seeing. So I think it's totally worth it to get the system just for the purpose of being able to manage any sort of specialty lens patient at a really high level as well. Here's just a couple more videos, just kind of showing some of the Fluorescein videos. So you can check for staining on the conjunctiva and the cornea. You can look at tear film breakup time if you're wanting to look at that. So it really is an excellent camera and video. Tear meniscus, you can measure the height of that by using the little annotation that's within the system. So you can measure it at different areas, and it'll just take an average of the different areas of the tear meniscus. Once again, I really like doing this because I feel like if the patient knows kind of where they start and they have something as like a base to measure against, they're much more likely to continue on with their treatment if they see they're actually getting better. Just some pearls for tear meniscus height. Measure the tear meniscus height right away. When you do any sort of other testing like NCT where you're blowing air in their eye, that's going to affect because they're going to have that tear reflex. Even when you do slit lamp, you know, having that bright light can affect how much they might have some reflex tearing. Of course, if you put any eye drops in, this measurement is not going to be accurate, but lots and lots of these tests that we're doing with the patients in our office, they're going to affect that measurement. So you want to make sure you do this right away. This is like the first test I do when I have the patient in the instrument. As far as what defines somebody that has an aqueous deficient state, this is something that's in literature, 0.25. I've seen 0.3 as well in other peer-reviewed studies. So I guess you can kind of take it whatever study you resonate with the most, but I would say 0.25 or 0.3 around that is anything below that's considered abnormal. Here's another question. Well, why can't I just use the phenol red thread test and Schirmer's? Well, because you're kind of irritating the surface even when you put like proparacaine in, that can really be an unreliable and not repeatable measurement. So if you think about it with Schirmer's, you've got this like sandpaper thing hanging out of this person's eye and you're trying to measure how much their tears are. But how accurate is that? We've just really found that the results are really not repeatable. Plus, it's really annoying. Imagine being a patient sitting there for 5 minutes and just to see how much tears they're producing. So it's really, I really think that the way that we're going with dry eye treatment and measurements, the tear meniscus height is going to be the least invasive way. You're not sticking something in their eyeball, and it's going to be super easy to measure. So that's the answer to that question that people sometimes ask me. Something else really cool, if you do any dry eye management to any extent, is the Meibomian gland imaging. I think this is so important if you're managing dry eye in the very least, because you need to be able to see what is going on with those Meibomian glands. Are they shortened? Do you have dropout? Do you even have any left? I mean, these are all important things to see, because if they have like no Meibomian glands left, well, you really know kind of what your limitations are. If their Meibomian glands look really good, then you're thinking, maybe it's not a Meibomian gland issue, maybe it's something else. So I think this is something that's really important to have if you are managing dry eye in any capacity. There's also the enhanced version. So with the same image on the left-hand side, and then you enhance the optics so you can just kind of see the Meibomian gland vessels more defined. So that's another interesting tool with the Meridia. There's also the grading scale that I talked about. So not only can we grade redness, so limbal redness, bulbar redness, we can grade corneal staining, we can do the Meibomian gland scale, we can do palpebral redness or roughness. So we've got these different grading scales available. So we're able to kind of move that, document where it's at now, and then repeat that test in a few months and then look and see if it has changed at all. So here's one of my patients where I'm just going to go through just some of the images so you can kind of see for yourself. But like this patient, what I'm doing on this right-hand side is I'm checking their conjunctival redness. So in this case, I just estimated, it's about a 2. For limbal redness, you can blow up that picture even more. In this case, I said it was like 2.5. Meibomian glands, this is also a really good scale, so you can kind of grade it based off of how much dropout you're seeing. Here's another patient where we're checking blepharitis. So if you look at the bottom eyelid, I'm saying, well, I do see some of these capped glands on the bottom, so I'm grading it around a 2. Corneal staining, a little bit hard to see on this photo, but she does have diffuse corneal staining. So in this case, I graded it like a 3.4, and then I'll repeat this when she comes back for her follow-up visits and see if her corneal staining has improved at all. Once you have all of these measurements and you've graded them the way that you want to grade them, you can actually generate a report, and you have the ability to put whatever test that you want on this report. So let's say you did a bunch of tests, but you really only think that maybe 4 of them are going to be relevant to the patient, or maybe you think it's going to be overkill having all of the tests on here, or maybe your patient is one of those that they want to see everything. So you can print out as many tests that you've done in the office and give that to the patient. Something else really cool on the right hand, you can see that you can actually input some of this information in on that dry eye report. And I just kind of blew this up so you can see it. But so for the top, you can put the risk factors. So like we said in the beginning, you can say, you know, maybe they're a smoker, they're Hispanic, and they're using antihistamines. You can put in their speed score. And then here's all the different dry eye tests that you can do in office. You don't have to fill all these out. I mean, a lot of us don't have all of these different measurements in office. But something cool is if you do grade the image, so let's say conjunctival redness you said was 3, it will populate in here as a 3. So that's like one less step of something that you need to do. And then you can change it. So if you forgot to grade it and you go back and you want to change it, or you want to change it manually, you just type it in. So I think this is a really amazing asset, because not only can you put all of their measurements in that you've done that day, but you can also put in your treatments and recommendations. So they have on their printout exactly what you have recommended for them, and they know what protocol to follow. This is what the dry eye report looks like. So you just pick whatever images you want included, and then it shows them kind of where they are on that scale. And then on that last page there, the summary there kind of tells them what's going on with their eye, how severe is their dry eye, and then what your treatment recommendations are for them. That way they just have a full picture. They can take this home and they can really get a clear understanding of what's going on with their unique situation. So I'm going to take a few questions from John, and then we'll go through a case report.
Yeah, so Stephanie, I'll wait for some questions, but in the meantime, you mentioned about the DEWS-2 report and possibly how it can work into your workflow. How do you work your workflow with dry eye and your scleral lens and your Ortho-K? So how would a patient come in, and how would you be able to screen them? So
Oh, that's a great question, John. So whenever I have a patient come in for a consultation, no matter what type of consult they're coming in for, part of their workup includes dry eye testing. For me, I really like doing their tear meniscus height. I like doing their NIKBUT testing, and their conjunctival redness. I think those are things that I find really valuable. And then I also do some fluorescein staining as well. So those are like the things that I feel are the most helpful to me as a practitioner. But the beauty of the Medmont is you can structure it to your workflow. So let's say you want to do all the testing, you want to do palpebral redness, you want to do limbal redness, you want to do conjunctival redness, you want to do staining. If you want to do all of those things, you have the ability to kind of pick and choose what you want to do. So for me, anybody that comes in for a specialty lens consult, they're automatically getting the tear meniscus height, their NIKBUT, they get a topography, of course. We grade their conjunctival redness, and then we do some staining. We also check their Meibomian glands as well. So that's kind of my personal workflow. And then I actually show the patient all of those images. We look at everything together, and then we can figure out what's a good game plan for them moving forward.
Great, thank you for that. So a question came in, and if you do have a question, please go to the chat box or the Q&A box down below. There's a little ribbon below that you can type it in, and we'll try to get to your question as soon as possible. So I got a question from a participant. How long does the full DED assessment take for a given patient?
Great question. So it depends on what you want to do in your workflow and how many other dry eye tests that you have in office. For instance, if you have osmolarity and you're doing that, or you have inflammatory, let's say you're doing that, and then let's say you're doing fluorescein staining and lissamine green staining, you know, the list can go on as far as what your exact protocol is. If you're doing just what is in the Medmont, as far as you don't have any of the other stuff, let's say, and you're just doing kind of like all the dry eye testing that's included there, I would say it takes less than probably 5 minutes to do it all. So you could do their tear meniscus right away. You do their NIKBUT. You take images of their conjunctiva and their lids and palpebral conj. And then you would do the infrared for the Meibomian glands, and then you would be done. So I would say less than 5 minutes if you are doing everything that in the Medmont. It'll be more if you are doing some of the other ancillary testing as well, as far as, you know, osmolarity and other stuff that you might have in office.
Great, great. All right, thank you for that. I have another question here. What order would you test osmo and inflammatory with the Meridia testing?
Good question. So I always think that you absolutely need to do tear meniscus first and NIKBUT. So those are like the two things that, like, before you do anything else, like I don't even check their vision before that, because I think that if they are looking through the occluder and they're like blinking to see and their eye is open, I think that that can even affect the measurement. So like the very first thing that I do personally is I do their meniscus and their NIKBUT right away. Of course, for osmolarity and inflammatory, you can probably do those after those two tests before you do any of the other stuff. But you could also do like the imaging as far as the conjunctiva and everything goes. And then you would, of course, do your osmolarity and then your inflammatory, and then you would be putting in the fluorescein or the lissamine green, because you don't obviously want that to affect that measurement.
Great, good answer. Got a couple more. Do you feel if a properly fitted Ortho-K lens would cause or exacerbate dry eye issues?
That's a good question. I have several dry eye patient or Ortho-K patients where we're managing some dry eye issues. I would just only speak to my own clinical experience, and I think that having anything on the eye compared to the naked eye having nothing can sometimes cause some dryness, like any contact lens patient. So even though the patient's not wearing the lens during the day, they're wearing it at nighttime, that they could still have some sort of dry issues, just for the pure fact that they are wearing a contact lens and it's altering the tear film and the shape of the eye. So there are some patients with Ortho-K that we're having to kind of manage dryness as well.
Great, thank you. One more question here, or two more questions here. Do you do homeostasis tests?
So you're probably referring to like the osmolarity, like just checking on that. I personally don't. I know that there's a lot of testing on it and kind of back and forth. I didn't find it personally super valuable as far as information. I thought it was really variable. Maybe that was because it was like in the very beginnings of it, and maybe I wasn't doing it right. I don't know. But for me in particular, I haven't found that to be super useful in dry eye progress. And that's, like I said, just me as my own clinician and managing my patients. I didn't find that super helpful compared to some of these other tests.
Great. One final question, and then we'll move on. This is sort of a segue, I think, in what we're leading up to. How do you charge for a dry eye workup?
Great. So I'll leave that, John, because I've got some slides on that coming up.
Okay, great. Well, let's keep moving then.
Awesome. Okay, so I'm just going to kind of go over just a typical case report with you guys, and then this kind of will show you what we're looking at and then how we graded each test. So I've got a 72-year-old white male. He's had cataract surgery with implants in both the right and left eye. He says his eyes constantly feel dry, scratchy, and irritated. He uses artificial tears every 2 hours, and he does use antihistamines for seasonal allergies. He does have, when we checked him, we've been managing with another doctor as well. He does have evaporative dry eye in both eyes. He's got Meibomian gland dysfunction. He's got blepharitis. So we said we're going to start some eyelid scrubs as well. So on top of his artificial tears, change his artificial tears to preservative-free artificial tears. We're going to start doing some warm compresses with him, and then also get him on some gel at nighttime. We also fit him into a scleral lens for the right eye because he had some irregular astigmatism from something else, and we wanted to have him come in about three months from now. So 3 months later, so he came in to see me. This was earlier this week. So we checked his vision and tear meniscus height, right eye, left eye, NIKBUT. We checked the blepharitis, so I checked his eyelids themselves. We checked his Meibomian glands to see if there's any change there. We looked at the conjunctival and limbal redness and palpebral redness. So these are the things that we just checked today. We also did staining. I just didn't have a picture of that. But that was kind of, these are the tests that I felt were important to look at his 3-month follow-up. So first we check his tear meniscus height, and this looks pretty good. This is under the white light. We can also do it under infrared, but in this particular case, I thought that it looked a little bit sharper here. We did that on both eyes, so we just kind of measured it, and those measurements will go right into the dry eye report, so you don't even have to worry about doing anything there. The video I couldn't get to play here, but basically is very similar to the video we already saw. So we're kind of evaluating the tear film breakup time. And something that's kind of neat here is you can see on the right-hand side that there is an auto TBUT. So the instrument will automatically put in a number, so in this case 2.5 seconds. But if you don't agree with that, maybe you're looking at it yourself and you just don't think that that's an accurate number, you can always change that when you go to the dry eye reporting. But I think it's great because it just automatically plugs in a number for you in case you forget, or you get to that point and you're like, oh shoot, I didn't remember to write that down. It's already got that in the report, which is great. So next, what we did is I looked at his eyelids to see where we're at as far as his Meibomian gland dysfunction. So he's at a 1.2. That's what I would grade it at. He's got some of those capped glands, but not a lot of issues. He didn't have, like a level 4 is like really bad. He wasn't nearly that bad. So I graded him around a 1.2 there. Looking at the right, or the left eye, I graded him a little bit less at a 1. And then blepharitis, I know that this grading scale just shows the bottom lids, but I always check the top eyelids as well. So in this case, you can see there are some collarettes at the very base of the eyelashes and some areas there. So in this case, I just said I'll grade it around a 2.5. The conjunctival redness, so I'm just kind of comparing the image compared to the scale. And in this case, I said, well, it's around a 2.5. And same thing for the left eye. Thought that the injection was a little bit more on this eye compared to the right eye, so I graded it about a 3.1. And then the limbal redness, just seeing if there's any issues there and how we can kind of grade the limbal injection. So in this case, for the right eye, I said it was a 2.4. And the left eye, I think it's a little bit more. I think we can agree that this eye is a little bit more irritated, so I graded that as a 3.0. And then the Meibomian glands. So when we look at the lower Meibomian glands, I mean, there's really not that much there. You can see that there's barely any Meibomian glands left. So in this case, I graded it as a 3.7. It's really almost like a 4, but because he had like some Meibomian gland function there, I didn't give him all the way as a 4 because he still had some left. And then the left eye, I thought that one looked a lot better. So you can see that his Meibomian glands are going a lot further back and he's got more of them. So I didn't grade that one as bad, so 2.6 I would say. I also just graded the redness of his palpebral conjunctiva. So again, this scale is just showing like an upper eyelid, but I think it's also important to check on the lower eyelid as well. So in this case, I graded it a 1 on the right eye and a little bit more on the left, 1.3. So then we get to the dry eye report and I just clicked all the tests that I thought were important and I just clicked all those and put that in his report so that he would kind of have a visual of what's going on. And then on the right-hand side, this auto-populated based off of the images that we took and we graded, and then I just adjusted the ones in here that maybe weren't graded. So like the corneal staining, I did that in a different exam room, so then I just graded it myself. So we also put here the risk factors. He uses a computer all the time, aging population, he does have Meibomian gland dysfunction, and he also uses antihistamines for allergies. So in the diagnosis, I've got dry eye, evaporative, severe, and then here's all my treatment that I recommended for him. Continuing his lid scrubs, preservative-free artificial tears every 2 hours instead of 4 times a day. Keep doing the warm compresses twice a day, using his gel at nighttime. I then incorporated omega-3 fatty acids, so getting him started on some fish oil, and then continue the scleral lens wear for the right eye to help maintain that eye. Here's the report. So just an example of kind of what we gave to him. So he's got a full printout of all the different images that we want to include along with that summary with our treatment plan. So you have to ask yourself, you know, as a practitioner and in your practice, you know, how can having a dry eye instrument help you as a doctor? And I think clinically, it's going to provide you with this really, really high level of caring for your patients because you're able to diagnose and treat dry eye at a very, very high level. You also have this amazing technology that's going to get you high quality images, and the fact that you're able to grade them, that will give you a way to see if the patient is responding to your treatment. I think the dry eye report's really easy to understand and follow, which is huge. You know, a lot of times patients, they don't follow through with the protocol or they're not compliant with their medicines because they don't understand why, or simply they don't write it down. So they can't remember doing all these different treatment options that you've told them because there's so many things involved and they just kind of give up. So with this, it's all written out for them. So it's really, really easy to understand. Something else that's really important clinically is that patients are able to see that report and they can compare with themselves. You know, if they're keeping them for themselves and taking them home, they can see how they are improving over time, which will keep them compliant with their dry eye protocol. As far as workflow goes, it's really easy to get used to this system. There's other instruments out there that not only dry eye stuff, but, you know, other tools. You know, you think of like a fundus camera, for example. Some of them are so complicated, takes multiple technicians. With this machine, it's very, very easy to use. It's small. It doesn't take up an entire room, which is awesome. And it's really easy to use. So one person can do all of it, which is great, especially if you're limited on staff. Economically, you know, it's really small, so you don't have a giant space that you have to host this thing. Because you're going to have higher compliance, you're going to be able to keep up with the dry eye program, the supplements, if you're selling any of those in office. And the patients are going to remain more loyal to you because you've got this high-tech equipment. You're able to treat this disease at a really, really high level. This is one of my favorite before and after photos that I absolutely love showing patients. But here's a patient that she had really, really, really dry and sick eyes. You can see on those top photos, her eyes, not only are they red, but there was edema, there's swollen tissue, and you can even see she can't even really hold her eyes open fully because they're just in so much pain. She had a condition where she had lots of punctate keratitis, and that's why we got involved with scleral lenses on top of all of her other dry eye regimen. But you can see after only 3 months, look how much whiter her eyes are. So they're a lot more, or a lot less inflamed, a lot less red. And her eyes are even wider. Her palpebral fissure has opened up. This is not her opening her eyes fully. This is her just naturally in the machine, just looking down the tunnel normally. So this is like so powerful, I think, when you have patients where you can say, look how awesome your eyes are doing. So if a patient's like, I'm not sure like if I'm doing that much better, or they're kind of questioning things, this is so powerful for them to see, like, oh my gosh, that was my eye. These are my eyes 3 months ago. And then this is my eyes 3 months later. That's incredible. So that's so encouraging to them to continue with their treatment protocol. So I think having anterior segment imaging is just like, it's so helpful for patient compliance, and then, documenting how they're doing. Getting into the financials, there's a huge annual revenue income potential for patients. Let's just say you see about 30 patients a day. Let's pretend your dry eye workup is $99, and let's just pretend your follow-up fee is $45. And let's say you sell supplements in your office, drops, masks, gels, fish oil, whatever. Let's just say it's $100. So if you look at the ROI, if you had, let's just say 5 patients a day that end up getting worked up, and then part of them, 50% of them, convert into a dry eye patient through your protocol, you can generate, you can see like $30,000 extra per year if these were the numbers that were appropriate to your clinic. And then on the high side, if you've got 40 patients a day, I mean, that's like a huge profit center in itself. So dry eye definitely has a place as far as it's a niche within optometry. And it's something that now with this type of instrumentation, we're able to diagnose at a really high level, and we're able to treat and manage them. And we're able to see if the treatment options that we are prescribing are working. I mean, how many times have we tried an eye drop and the patient comes back a few months later and they don't feel that much better? But if you show them, wow, look, your non-invasive tear breakup time, it is improved, your tear meniscus height's improved, your redness has improved. So even if they don't see that things have been improving on their end, you can show them like, look, this is actually improving. Or on the other side, maybe they're on this incredibly expensive eye drop, and you do all these tests a few months later, and there's like no improvement. And in some of my patients, it like gets worse. So in that case, well, what's the point in spending so much money on these eye drops when it's not really doing anything? So it's just a really good way. So instead of just guessing and saying, well, like, this is all we can do, let's just see if it works. This is a really, really, really great way to be able to see if what you're doing is working. As far as billing goes, this is a question that, of course, we always get. Of course, with your comprehensive exams, you'll use your 92004 and 92014, depending on if they're a new or existing patient. And then I always have my patients come back for a dry eye workup. During their comprehensive exam, if I see that there's any signs of dryness or they're complaining, I always have them come back on a different day. And that's just because a lot of these things, they won't reimburse the same time as this and that. So it's just easier for them to come back. And then it helps with the workflow. So the staff knows exactly what tests you want done, and it's just a lot more efficient. So I would recommend not doing a lot of these tests during the same time as their comprehensive exam. Some doctors, they will do osmolarity on the same day as their comprehensive exam, or they'll do imaging, you know, whatever is best for your practice. But for me in particular, I always see them for their regular exam, and then I always have them come back for a dry eye workup. For the office visit, you can use your level 2 or 3, so 99212 or 99213, whatever is most appropriate for whatever you're doing in the office. The 92285 is the external photography. So this is if you're trying to document with a photo their punctate keratitis, their blepharitis, maybe they have an eye growth, a lot of these patients do, maybe they have a pterygium or a pinguecula. So these are all billable items that you can send for external photography. Tear film imaging 0330T. There's a new one, 0507T, which is more appropriate for this instrument because you are doing meibography with infrared imaging. And then if you do have inflammatory, that's the 83516. If you're doing tear osmolarity, that's 83861. And then any other extra services. Let's say you offer IPL, the laser in office. Maybe you have like a LipiFlow or some other tear lux or whatever. You've got lots of different things that are out there. So those are also income generators. And then products. So you might sell eye vitamins in your office. You might sell different eye drops or gels that patients can only get through you. They can't just get them down the street at one of the drugstores. And even makeup. So they actually make makeup now that is specifically geared for patients that have dry eye. So these are all things that can provide extra income to your office and really all geared toward these dry eye patients. Other opportunities that we didn't even discuss in either of these financial protocols is punctal plugs. Those reimburse at a great rate for most medical insurances. And then dilation, irrigation with or without irrigation. The dilation and irrigation of the lacrimal punctum, you know, that's something that I do frequently as well to find out if there's anything going on with the eyes. Maybe there's a problem with the drainage, you know, we don't know. So these are just some very common codes that you can use with some of these dry eye patients. So you just have to figure out for yourself, is a dry eye practice right for you? You have to figure out if it's going to fit in with what you're doing. Most practices, it would be a huge asset to incorporate some sort of dry eye technology into their practice. There's just so many patients that have it, like I said, with kids even now, with all the screen time and such. But there's so many patients that have dry eye. A lot of them are going undiagnosed, and then when they are finally diagnosed, they're already at this really bad, you know, moderate to severe stage. So if we can diagnose patients a lot sooner and get them on a treatment program, then that's going to be huge, you know, not only for the patient, but for you as well. So, you know, lots of different options as far as dry eye goes. I think it's such an incredible era that we're in, because we have discovered that dry eye is a huge part in eye care, and it causes a lot of problems with everything. So if we can get these patients diagnosed and treated quicker, we're really going to have a huge positive impact on their lives long term. So I'll take some more questions, John, if we want to wrap up. And of course, if we don't answer them, please email me. My email is drwu@clinevada.com, or you can get a hold of me on my website. I'm happy to answer any questions if they don't get answered this evening.
Yeah, so Stephanie, we'll take one question. We're beyond the hour a little bit, so we'll just take one question here, and it just came up. So how would you treat a patient with minimal to none Meibomian glands?
Yeah, that's tough. So that's kind of like that mystery area where you've got a dry eye patient where you look and you're like, Meibomian glands look relatively intact, but they're still having these symptoms of dry eye. So of course you want to check the Meibomian or the tear meniscus height, because it could be like an aqueous problem. The Meibomian glands might look fine, but if they don't have enough liquid on their eye, something as simple as incorporating artificial tears or plugging up the punctal, using punctal plugs can really help to just keep more liquid on their eye. If that's still not working, I still have them start on an omega-3 supplement to have a more high quality option as far as like their tear film, and I still have them do warm compresses. As far as prescription eye drops, I will also probably start them on something that can help lower inflammation, because we've really discovered that with dry eye, inflammation is one of the key components. So getting them on some sort of anti-inflammatory and then checking them back in a couple weeks can certainly kind of guide your treatment process depending on what happens with that.